program, and we are అంటే now that మామూలుగా నేను నా భాషలో చెప్పాలంటే సీనియర్ యాక్టర్లు కొంచెం క్యారెక్టర్ యాక్టర్లు చేసేసేసి జూనియర్ యాక్టర్లు హీరోలు అవ్వాలి కదా, సీనియర్ యాక్టర్లు హీరోలకు గెంతులు పెడతామంటే కుదరదు. అందుకని నౌ దట్ మై సెకండ్ జనరేషన్ టీమ్ ఈజ్ ఆల్రెడీ టేకింగ్ ఓవర్ ఎట్ గుంటూరు. సో ఐఎమ్ రియలీ హ్యాపీ టు ఇంట్రడ్యూస్ బోత్ దీస్ kids. I don't really call them kids. Anyway, they are my junior colleagues who are coming in, and so Guntur ki new blood infuse చేస్తున్నారు వాళ్ళు. So I invite both Uday and Kalyan. Most of you have seen them anyway. Guntur వచ్చేప్పుడు మీరు అందరూ వాళ్ళని చూశారు, వాళ్ళు చాలాసార్లు మీట్ అయి ఉంటారు. So I call both of them to speak on their topics today.
Sir, first Swami sir మాట్లాడతారు sir.
Okay.
Respected President Madam Krishna Prasanthi Madam, Chairman elect Rambabu Garu, other dignitaries like Alladi Mohan Garu, S. Ramanamurthy Garu, MBR Sharma Garu, Prabhakar Garu, and other dignitaries who are about to join also. I welcome you to this today's academic program by APA, which is being conducted since 2-3 months. Good evening, one and all. And I request today's meeting to be conducted by our Chairman, Dr. Krishna Prasanthi Madam.
Thank you very much, sir, for your kind words of introduction. Respected legendary physicians of APA and the respected attendees of today's continuous professional development program, and the esteemed speakers of today's CME, Dr. Uday Shankar, Dr. Kalyan Chakravarti Garu. So we really thank you for accepting our request, and I thank Dr. Prabhakar sir for coordinating all these topics and everything. Every month we are conducting this kind of program. This is the third meeting we are conducting. It's only to encourage all our colleagues to give a platform to present and to share their expertise and knowledge to all the other things, because in all the national conferences and other state conferences we are seeing that the number of delegates sitting in the room is very less. By virtual we are connecting and we are able to spend more time. We can have the good interactive session, and we can always entertain the new innovative ideas from both the generations, as sir was telling. And really I thank Dr. K.S.R. Swami sir, and particularly Dr. Kiran, Joint Secretary in absentia, because he has done lot of groundwork for getting all these things done. And we thank VDO Technologies for getting all these things in a very short notice. And I invite Dr. Prabhakar sir to introduce the first speaker for today's CME, Dr. Uday Shankar.
Madam, small
Sir,
word.
Sir.
We have a national chairman and meeting. You can highlight 1 or 2 points.
Yes,
The last
you
week's
can please
meeting.
tell, sir. You can please tell.
They want to connect all state branches to their website. All academic activities they are also likely to host from their website, and all state academic programs like our meeting, they are also being connected. Whoever is interested to whichever state conference program they can join. They are introducing new methods to spread this type of academic activities all over the country, and our program will also be shortly linked to the national programs of APA. This is the, in essence, we have discussed in the last week's APA National Conference meeting with South Zone secretaries. They are interacting with various associations. First of all, they are discussed with our South Zone, including Kerala, Karnataka, Madras, and Andhra Pradesh, Telangana. This is to inform you, sir. This is what is likely to happen in future regarding our academic activities.
Yes, sir. The point in addition is ICP Dean Dr. Jyotirmay Pal will be sending the mails and everything, and I will be sharing in the EC group. And kindly, I request all the zone vice chairmen to be very active to coordinate with all the dynamic faculty in all the respective medical colleges. And definitely we'll be having a very short, in a short period, we'll be connecting with the city branches. And the 2 important requests is all the city branches should be registered under the Societies Act. Whatever activity you are doing at your local branch level, kindly share to us. We'll be informing to the national API. Every state will be giving a link, and all these activities will be updated so that national API will be knowing what exactly our Andhra state is doing. So we request all the enthusiastic young generation doctors to be very proactive in submitting their anything, whatever you are doing. So we'll be connecting to the nation so that we'll be having more opportunity to be at the national level also. Thank you very much. And I request Alladi Mohan sir to kindly tell about one point regarding the postgraduate program, sir. In brief, later we can go on to the CME.
Yes, sir. Sir, the making the impossible possible is what I live in my clinical life. The 2-day program is going to happen on 25th and 26th. The detailed program, I'm stuck with the institute day tomorrow, and the detailed program will be shared in the more or less detailed program will be shared by Madam during the 12th of March meeting. And kindly the peoples who are visiting should make the travel arrangements. It will include a blend of case discussions in the form of mock examination. There will be a interlude with the labs and imaging, as well as discussing difficult cases. I couldn't meet Madam and sit with her because last couple of days we are lost to follow up with our institute day. So tomorrow I'll be visiting Madam. We will make this happen 25th and 26th of March at Tirupati in the institute. That is the Sri Venkateshwara Institute of Medical Sciences, Tirupati.
Thank you, sir.
Thank you, sir. Thank you very much.
Because those who are interested to attend, kindly make your travel arrangements. Scientific schedule detailed program. Sir is busy with the Institute Foundation Day. So after that, we'll be letting you know. So I think sorry for the delay. Now I request Prabhakar sir to introduce Dr. Uday Shankar sir.
I think I got only Uday's introduction.
Yes,
I
sir.
have the other one, sir. Dr. Kalyan is with me, sir.
Okay, fine. So, what should I say about Uday Shankar? You have all seen him, you know him anyway. Uday Shankar is one of the dynamites of Guntur here. Okay, right? So I know him ever since he was a student, and he comes from a family of doctors. I'm not exactly reading out what is sent. His qualification, etc., from Davanagere and Bijapur Medical College and all that. And he straight away came into practice, and he is coming from a kind of family who has got political connections or political life. Actually, his mother was a minister for health during N.T. Ramarau's government, and I had the opportunity at that time for treating the minister for health for her treatment. So at that time, actually, I was visiting their house and all that. That's when I really came into contact with Uday. Right, Uday? Is that or even earlier? You know me.
Before only, sir, madam.
Even before you were, you were working in St. Joseph's Hospital at that time, right?
I was house agent then, sir.
Okay. So then, after the qualifying, he has got developed interest in that geriatrics and their elderly people and their problems. So he will talk to us about the sarcopenia in the elderly, is a major problem during elderly life. They tend to lose their muscle mass and become sick. So go on, Uday.
Sir, I would like to introduce the second speaker of today's program. I am privileged to read the Dr. Kalyan Chakravarti K. graduation. He is graduated from Guntur Medical College and post-graduation from Manipal Academy of Higher Education. Awarded PG certificate in infectious diseases from London School of Hygiene and Tropical Medicine, UK. Started Center for Infectious Diseases in Guntur with state-of-the-art microbiology lab supported with automated culture systems, PCR and CBNAT technologies. In December 2019, with the help of young and enthusiastic super specialists, started Samista Hospital and Research Institute, SHRA, which is first state-of-the-art critical care unit of AP with isolation cubicles supported by air handling units. presented papers at various international conferences on infectious diseases and antimicrobial resistance. The best being the role of APTT in avoiding platelet transfusions in dengue, presented at ECC MID 2017, and the COVID severity index at ECICM 2022. With this brief introduction,
Swami Garu, in fact,
Sir.
Kalyan has started those negative pressure rooms and
Yes, sir.
isolation
Aid
wards
handling units.
much before the COVID has come.
Yeah.
He was kind of COVID ready.
That's
Even
excellent,
before the COVID has really come.
Future ready.
Yeah,
Thoughts.
he was future ready. He was expecting COVID to come in.
That's nice. Very nice, sir. Kalyan, sir. Sir, we will go ahead with our academic program, sir. Dr. Uday, sir.
Thank you, sir. Thank you for the kind introduction. Madam Krishna Prashanti, Ramurthy Garu, Dr. M.B.R. Sharma, Swami sir and all, and Dr. Y.V.S. Prabhakar, who's always been my good mentor. Thank you for the kind words of introduction. Today, we'll be talking about a fairly common, fairly prevalent problem in elderly, that is sarcopenia in the elderly and its implications in aging. I'm a physician and a geriatrician by work, and I'd like to declare that there is no conflict of interest. There is no conflict of interest to declare. Now, before we go forwards, we all know this. No one can miss him, Shammi Kapoor, and he is famous for these wonderful songs, Chahe Koi Mujhe Jangli Kahe. However dynamic he was, he had to age. Aging is omnipresent. We cannot escape aging. And the most important is how effectively and how gracefully do we age. When we talk about aging, we all say, it is bound to happen. But what is important is, at an age where you cannot perform, how independent are you? And today, we have to see how independent are we. Now, the most important group which is concerned with aging and work on aging is the European Working Group on Sarcopenia in Older People, or EWG SOP. This is the foremost and the most premier group working in the world towards aging and complications in aging. Now, aging, though all of us know about aging, there hasn't been much work done in the past 30-40 years. The work has actually picked up from 2007-2008, and in the past 5 years, there's an explosive interest in aging and its management. By definition, sarcopenia is, sarx is muscle, penia is loss, and it is defined as an age-related. Please mark these words. It is not a disease. It is not a disorder. It is an age-related involuntary loss of skeletal muscle mass and strength. I'd like to reiterate that it is an involuntary loss of skeletal mass and strength. You have signs of sarcopenia starting as early as in the 4th decade of life, and the evidence of skeletal muscle strength and mass decline starts in a linear fashion. It's a linear fashion, it is not a geometric one. Over the years, you find that the patient starts getting weaker, has a bit of difficulty in performing works, starts getting fatigued easily. And all of us, including doctors till recently, used to attribute it to aging. Now, is it just aging, or is it aging or something else? What are all the factors which are behind aging? And the most recent thing, 2023 January, is the reversal of aging. Is it possible to reverse aging? So these are the things which we're looking at today. We will be trying to summarize these things in a very short time because of the lack of time. However, the important point is, by the 8th decade of life, once a person enters his 8th decade, 50% of his mass, body mass or muscle mass is lost. Now, this was a model which is extrapolated to humans, and they found that at the 4th decade or the 5th decade, if a patient has an injury or a disease, the recovery is never complete. There always is a damage followed by destruction or proteolysis or loss of muscle mass, but the recovery in that is never complete. It never ever touches the baseline. And unless and until we are prepared for that beforehand, unless and until you are prepared for this makeup of this muscle loss, muscle mass loss or power loss, we will have complications which are difficult to handle at the early, at the end, fag end of life. Rightly, as said by Dr. Ishwar in one of his lectures, if you want your next generation to be fit, you have to start exercising now. And if you want to be fit yourself, you have to start exercising yesterday. And unless and until we start planning this for ourselves and our patients, or incorporate this into clinical practice, managing will be a bit later. Now, this is a classical example of a patient's cross-section of the thigh and the calf muscle. The first picture is that of a young male who was normal, physically fit young male. You can see that there is not much of a fat in the thigh muscle area. And you can see that there is a lot of muscle tissue with very little interspersed adipose tissue. The second and the third pictures are age-matched 7th decade patients. If you look at this picture, the second picture, second middle picture on the top, you find that the muscle mass is less than adequate. The fat is significantly present, and there are a few streaks of adipose tissue in the thigh region, whereas the calf region, there is not much of adipose tissue. This is a 70-year-old man who has been regularly exercising and is an athlete, compared to a 70-year-old man who is not exercising, but though physically he thinks or he feels that he is fit. You find that there is a lot of fat in the thigh region. Even the calf muscle is replaced by fat, and there is adipose tissue in the fat in the calf muscle as well, which means that exercise is essential to maintain the muscle mass. Now, before we go any further, we have to identify this. What is a slow twitched muscle fiber and a fast twitched muscle fiber? Slow twitch fibers are responsible for stamina, where they're efficient for a longer time, and they fatigue over a long period. For example, if you run for a long time, at the end of 30 to 40 minutes, you get fatigued, and this is a slow twitch type 1 fibers. The type 2 fibers are bursts of energy, you get them, especially seen more in sprinters, and this is where you fatigue fast, the muscle gets fatigues faster, and these fibers are more common in men. Now, both the sexes, men and women, do have type 1 and type 2 fibers, but what we see is over a period of time, there is a transition from type 1 to type 2, and that is where your sarcopenia sets in. All these first few slides are about statistics, and this is where we find that the muscle mass linearly decreases in percentage and strength by the end of 8th and 9th decades. At the end of the 8th decade, you almost see there's a 50% reduction in the muscle mass and strength, and this is going to be inevitable. The reason why I have shown these slides is it just aging, or what are all the factors behind aging? Can we control them, and is it possible to reverse them? Till recently, it was like a taken for granted that no, once you age, you cannot reverse aging, and once you lose your muscle mass, you're done with it. But however, recent research has changed. For that, we have to go to the etiology of sarcopenia. Please note that sarcopenia etiology is not just aging itself. It is also genetic and hormonal. This is only an academic slide where these three alleles, the MTHFR, the actin-3, and the NRF, these are the major genes responsible for aging in men and women, in sarcopenic and non-sarcopenic, they found that these genes expressions were higher, and therefore aging is now thought to be having a genetic predisposition. Number one, in the sense that if these genes are expressed in these people, their aging is more. One. Second thing is there are a lot of hormones also responsible for sarcopenia. Now, I wanted to actually see what was the pathway for development of sarcopenia, and I tried to understand this chart. I could not. So I had to go back to my physiology. I read my physiology back and made a simple slide like this. And at the end, I was actually surprised to see that the most important hormone for muscle development is insulin. We call insulin as, probably wrongly call it as an obesity hormone, but in the elderly, it is a boon, because insulin or IGF, insulin growth factor 1, which stimulates that, is the most important hormone responsible for maintaining the muscle mass and bulk. I re-emphasize that insulin is the most important hormone responsible for maintaining of the muscle bulk in the elderly, especially in the 6th and 7th decades of life. The pathway is called the mTOR pathway or the Raposin pathway, where I'll simplify this. The mTOR pathway activates the phosphatidyl inositol kinase. Now, this phosphatidyl inositol kinase has two actions. One, it promotes muscle growth by cell signaling, cell growth, cell differentiation, and proliferation. At the same time, it suppresses the FOXO3 suppression, that's a FOXCRID suppression, which causes the muscle atrophy. Now, along with insulin, calcium, growth hormone, and testosterone have a role, but it is limited in muscle growth. Therefore, the most important hormone, insulin, stimulates muscle growth by activation of the peak IK and suppression of FOX3. Now, is it just hormones and mediators of sarcopenia, or what are the hormones and mediators of sarcopenia? Well, I would be surprised to see that all of us know that glucocorticoids cause muscle wasting. But how? Again, the pathway for that is a surface receptor, which agglutinates with the glucocorticoids, and these are responsible for muscle wasting or sarcopenia. Thyroid hormone supplementation in excess. We all know that hyperthyroidism causes, we all consider that by catabolism, it increases sarcopenia or muscle loss, but no, it is also a hormone. There's an elaborate hormone mediated cycle which causes muscle loss. And the presence of TNF alpha and interleukin 6 are all strong indicators of sarcopenia. Now, also a decreased testosterone, decreased estrogen and growth hormones, all the decrease in testosterone, estrogen and growth hormones also lead to muscle atrophy. So these are all the pathways in which you have sarcopenia happening in a person. It could be glucocorticoids, thyroid hormone, TNF alpha, interleukin 6, decreased testosterone, decreased estrogen, and growth hormone. Now, if you look at the clinical aspects of sarcopenia, which is more important for us as physicians, the most important feature they come and tell you is falling. However, a bit of caution here, falls in the elderly are just not because of sarcopenia, they are geriatric syndromes. There could be an associated Alzheimer's, the most important being Parkinson's, a peripheral neuropathy, and you should not even miss an arthritis. So all of this can cause a fall, but you have to categorize the fall based on its clinical features, whether it's a sarcopenic fall or whether it's a neurological or a central nervous system causing the fall. Again, the second system again could be a muscle wasting, a patient presenting to you like this with a classical peripheral wasting. It could be small muscle atrophy of the hands, small muscle atrophy of the legs. There could be a severe form of peripheral neuritis. In the elderly, there can be compression syndromes or entrapment syndromes, and it could be trauma, repeated trauma to the nerves, which can cause wasting. So even here, you have to define whether this is a muscle defect because of atrophy, because of age causing the muscle weakness, or central mechanisms or peripheral neural mechanisms which are in play causing sarcopenia. The third one, again, you have a differential of Parkinson's, you also differential of arthritis and sarcopenia. Rarely and occasionally in the West, people do report self muscle wasting, but it is a controversial thing because self-reported muscle wasting is appreciated only in thin individuals. There is one entity called sarcopenic obesity where the patient apparently is obese but has a lot of wasting. And the last and the most important thing is the patient complains that he has difficulty in performing a normal routine activity. For example, he says, "Monatadaka nenu neelu poskunevanandi, chatlaki neelu posevanni, lakapothe I was able to take my own bath, I was able to wash my own clothes, but now I find it difficult." Here, I would say, rather than physical anomalies, depression also has to be considered, and you have to rule out depression before you can really say that this is a sarcopenic anomaly. Now, the associations of sarcopenia. Well, sarcopenia in patients can have predispositions and predisposed to. For example, a patient who has sarcopenia is predisposed to diabetes, type 2 diabetes mellitus, predisposed to high blood pressure and obesity. And if a patient has sarcopenia, he can suffer from coronary sarcopenia, can aggravate coronary artery disease, stroke, and peripheral vascular disorders. So how do you, now this was when I wanted to see how to assess sarcopenia. What I found in the beginning was there's a lot of matter on that. But what is of importance is the last line. The chair stand test and the grip strength will be simple and useful tools for screening sarcopenia. Now, the West has a lot of literature where they talk a lot of CT scans and MRIs and DEXA scans and all. But when you want to implement that in a practical sense, I'm not sure because availability of all these in the peripheries is a challenge. So this is what the West says. This is what I do in my clinical practice. All of us know that this is a hand grip exercise meter. And I ask my patients to see if they can perform it 5 times. And if they can do it, then that is, it rules out sarcopenia literally in the upper limbs. Now, these are the 2 tests which the West says, the dynamometer or the hand grip meter. And I'm not able to play this video somehow, I'm sorry. Okay, this was supposed to be a video playing, it is not playing. If a patient can sit with both his arms crossed and stand up from the sitting position for a 30-second period, sit and stand, if he performs less than 12 cycles in 30 seconds.
Sir, double click on the video, sir, it will play.
Rattler, sir.
Okay.
Yeah, sorry, thank you. So if a patient can sit and stand for a minimum of 19 times or more in 30 seconds, then he is not sarcopenic. His thighs and pelvic muscles and the calf muscles are good enough. If he has less than 12 per 30 seconds, then there is some form of anomaly. And if it is less than 9, he definitely needs management. Well, technically speaking and theoretically speaking, the whole body skeletal mass index, and this is assessed by the bioelectrical impedance analysis or a lumbar muscle cross-sectional CT and MRI or a DEXA scan or a dual X-ray energy absorptiometry is what is prescribed in textbooks. I'm not sure how much of it we can do in Guntur. We can do an MRI or a CT in Guntur. But if a patient comes to me and says, "Naku weakness undi ante in an MRI dinchalante," a doctor marustadu. So I prefer to do a simple test, which is a 6-minute walking test in my OP. నా దగ్గర ఒక పాత TMT machine treadmill ఉంటే I kept it at 3 kilometers per hour and asked him to walk for 6 minutes. The ideal recommendation is 2.5 to 3.5 kilometers per hour. I kept it at 3. And generally, if I find that they can cross 3 to 4 minutes, they are okay. And if they can do 6 is great. But if there is a problem, they generally don't cross 2 minutes. They either stop working or they need assistance. Word of caution here, if it's an electrical treadmill which you're using, please make sure you have someone watching them, because you shouldn't walk and fall and break your hip and they say, we came for something and got something else. A standard thing in my OP, what I do is a 30-second chair raising test for all the people. It is a very easy test to perform. Okay, 1.5 feet height in a chair, pakkana, handrest lekunda, ask them to keep their hands like this and get up. Difficult to perform in elderly people, especially who are obese. Exercising elderly people can do it with very. And people who are slim and lean generally do it very well. A word of caution, especially in patients with heart failure, they may not be able to do it. They may find it uncomfortable. So I would be very cautious in advising this to patients with heart failure. Lung, renal diseases, hepatic diseases, rest all, they can do it quite easily. Hand grip test, as I've told you, any exercise shop, sports shop will sell that hand grip meter. 25 pounds per square inch. If they ask, if they can do it for 5 times without stopping, their grip is as good as normal. Well, one word which I would like to tell you here is dynapinia. Well, if you have a patient who's got dynapinia, sarcopenia is age-related. Dynapinia is disease-related. So if you have a diagnosis of muscle wasting, and then you need to check for dynapinia or reasons for dynapinia. Well, again, the management, this is a beautiful slide. It actually summarizes all the management of all the patients with sarcopenia, but difficult to read in the slide. So I've gone one by one. And the most surprising thing which we found is the ACE inhibitors and sartans, they have found to have a positive effect on patients with muscle mass, which we'll be discussing in the next trial. This is only for academic purpose, this trial. Now, pharmacological management. Now, as we have to talk about the most recent monoclonal antibodies, these have found to be these
speaker has, I mean, they have to mute that. Now they have muted.
Okay. These are the monoclonal antibodies which are found to be against myostatin. Myostatin is a protein which helps in proteolysis. So antibodies against myostatin, that is trevogrumab, landogruzumab, and these two monoclonal antibodies are found to be anti-myostatin antibodies, which are more theoretical. They have huge numbers, and they still are in the active phase of clinical trials. And the second one is still in the phase of recruitment itself. Ghrelin and mimetics again is in the phase of recruitment itself. Now, androgen receptor modulators also are in the phase of trials. However, growth hormone, testosterone, we know both of them are available clinically. Now, what happens when you give growth hormone to a patient who is elderly and above 60 years, and does it help in muscle building? A lot of research has been done, and honestly speaking, I've tried in one patient only and found that this fellow had heart failure very shortly. So I would not really recommend it in clinical practice unless you have a very, very, very well controlled monitoring over the patient. Growth hormone is known to cause heart failure in elderly, especially when you supplement it for the muscle building. Testosterone. I have not tried testosterone in any patient who needed muscle building, but the effects of testosterone in women are masculinity and it actually accelerates prostate cancers and prostate malignancies. So that is the reason why we have never tried testosterone at our setup till now. Well, it will be surprising to see that metformin will be probably the B complex of the next decade or century. Metformin has been found to have a role in kidney reversal, renal protection, PCOD, name it. Metformin is supposed to be a wonder drug, and this drug has been tried in mice and found that metformin has increased the life of mice in an age-matched. They've taken a 120-week mice and given it metformin, and another set of mice at the same age was given a placebo. Found that metformin given mice survived 8 weeks more. Though it is a insignificant thing in terms of weeks, when you extrapolate that into humans, it is found to be a very large thing. They also found it was an incidental finding in 65,000 patients, where they found that people taking metformin, the muscle mass was larger. A surprise finding also, that is regarding the ACE inhibitors and the sartans. They found that people on ACE inhibitors and losartan especially losartan, they found that their muscle mass was higher, and they found that ACE inhibitors helped in muscle building. There's an elaborate pathway and sequence which I can share if anyone is interested. Vitamin D3. If I say this, it will be funny, but the best source of vitamin D3, as all of us know, is sunlight. And unfortunately, we're rewarding sun by the day. It was found in a cross-sectional study in India and in the Southeast Asian countries that people in the villages especially had a better muscle mass than the so-called counterparts in the urban areas. And the sole reason was vitamin D3 in plenty. Well, this is a miracle drug by Japan. Most of the Japanese people, they'd like to live longer. They say they have funny reasons why they live longer, and one of them even being sexual intercourse. They say that more sex, more life. And so they found that these are the reasons. This is Ningen Yoto, which is a miracle drug in Japan where they live longer. And then I googled up what Ningen Yoto was. It was nothing but Dalchin Chakka, Kamala Pandu, licorice, even. So what our ancestors did over a long period of time, which we have left in the name of the West or aping the West, if we kind of include those back into our diet, I think we will be able to do better. Well, the genetics of sarcopenia and age reversal, is it possible? Is it there? Is it not there? There was a very interesting experiment done on mice where there was a genetic modification of the mice by some slicing of the genes, and they became blind. And then they delivered this cocktail called the OSK cocktail, which contains of these three gene segments, OCT4, SOX3, and KLF4, by David Sinclair, who was given the Nobel Prize in 2019. And in his most famous words, he said that it was like rebooting a malfunctioning computer, which means actually a blind mice called the ice mice who lost their vision got it back because of this gene transformation. This study was done at Harvard Medical School, that is the Center for Biology and Research, and it has given a lot of insight that aging can be reversed. 1, sarcopenia can be reversed. 2, and with a bit of planning, a bit of exercise, we can definitely increase the quality of life, not the lifespan, please mind it. We can definitely increase the quality of life of the elderly. To summarize, sarcopenia is an age-related condition which makes it difficult to determine whether it has any effect on the life expectancy. As I just told, we can definitely increase the quality of life, but not the length of life. It is clear that this condition has an effect on the quality of life and it can be greatly improved by effective exercise planning and nutrition. Sorry, by saying nutrition, it is not consuming red meat or stuff like that. It is just consuming antioxidant rich diet. People who maintain a sedentary lifestyle following diagnosis of sarcopenia may have a greater and a faster muscle loss compared, and if you do not take care of sarcopenia, we generally may be blood-ridden. The take-home message in sarcopenia is we have to inculcate exercise into our lifestyles. When you look at the literature, it says you talk about resistance training, you talk about muscle training, you talk about all these. I don't know how much of it can be practically inculcated into our lifestyles. నేను చెప్పేది ఏంటంటే మా పేషెంట్స్ అందరికీ గార్డెనింగ్ చేయండి అరగంట సేపు ప్రతిరోజు. ట్రై టు వాక్. If you want to go outside, don't go on a vehicle, try to walk. And you have to avoid the high carb diet, that is this especially bakeries. One of my friends who's a professor and research scientist in Bapatla Engineering College, he came to me recently and said, what do you prefer eating? And I was trying to tell some vegetables. He said, it's funny to listen. Purugul tinnai tinali manam mundu endukante there's so much of pesticides in them that even the right way to identify is eaten by insects. So we have to come back to a diet where preservatives are free, fresh, probably organic, and then yoga. Yoga is one of the best resistance training exercises which you can actually follow. Yoga lo entante gentle ga they do this stretching, which is beneficial for the elderly, which is good for the elderly. And I don't know how much of you know the benefits of Surya Namaskaram, but a person who can do 8 to 10 sets of Surya Namaskaras per day may not have any disease in a long time. I have one of my uncles who does 12 to 25 sets a day, 12 in the morning, 12 in the evening, and is really, really healthy, much healthier than me. Antioxidant rich diet. And then I asked this question to one of my friends who's a nutritionist, and he said, anything colored is rich in antioxidants, especially these red color, that the lycopene colored things are good. Traditional spices in our diet is good. And an important thing is you have to have an adequate control of comorbid conditions like hypertension, diabetes, heart failure, and thyroid disorders. These are the take-home messages which I'd like to say. Exercise, and exercise. Include gardening in your lifestyle. Cut the vehicles which you want to go out for. I see a lot of my friends coming in their BMWs to exercise. So leave the BMW in the house, come walking to the exercise, the cycling, and then you have to avoid the high carb Western diet. Inculcate yoga and Surya Namaskaras in the patient's lifestyle, an antioxidant rich diet, and our traditional spices like cinnamon, all these things help, and proper adequate control of comorbid conditions will help us a lot. I thank you all for the patient hearing. I think that's about it. Thank you so much.
Thank you very much, sir.
Can I
I
speak,
think-
Dr. Ramanamurthy?
Yes, sir. Yes, sir.
A wonderful lecture. Only thing is to give certain drugs like testosterone, other things, but to establish the diagnosis of sarcopenia, there must be some diagnostic criteria. I feel, of course, to prevent sarcopenia, we can go for Surya Namaskaras, everything. When once we enter into sarcopenia, there must be some diagnostic criteria to say mild, moderate, or severe. May
Yes, sir.
know. Thank you, sir.
Sir, there is one slide which is missing in this. It is called SARC-F slide. That tells us whether we can diagnose sarcopenia or not. I somehow missed the slide in this presentation. There is a criteria for that SARC-F criteria. And based on that, we can diagnose whether the patient has mild, moderate, or severe sarcopenia.
Okay, thank you, sir.
Yes, sir.
ఉదయ్ అదేంటి
Thank you, sir. Thank you.
30 seconds లో 19 times లేవాలా?
Minimum 12 times legal, sir.
భలే వాడి ఎట్టబోతున్నాయి బాబు. Can anyone really do that? I don't think I can do that.
That's done with a bit of caution, sir.
అంటే I do get up when I'm working in the OP and all that. I make it a point to get up without holding the hands on the chair. I try to get up straight. Whenever I always see the patient on the couch. So sit in the chair at the table and every time get up and go to the couch. So every time I try to get up without holding the hands. But all the same, if you want me to do it 10 times or 12 times in 30 seconds time, I don't know.
It is difficult, sir. It's not that easy, sir. Actually, it's కష్టమే. First 4 patterns మనకు కూడా ఆయాసం వస్తుంది.
మోకాళ్ళకి వస్తాయి ముందు.
అందుకనే the height
History
is
of falls
prescribed,
will be
sir.
there, sir. History of fall will be there. Fall from the chairs, what we are using, that movable chairs. I think one lady doctor has fallen on the back and she sustained a fracture also.
Spine fracture అవుతున్నప్పుడు.
Yes, sir. So I think if there are no questions, can we move on to the second thing, sir? Then we
Yes,
can have
madam.
the discussion.
Yes, madam. Yes, madam.
Already it's 9 o'clock.
Sir, we'll go ahead with the second topic, sir.
Yeah, Dr. Kalyan.
Evening, madam.
Yeah, good evening. Nice to see you on the board.
Thank you. Thank you. Can I screen?
I think you have to share your screen.
Dr. Kalyan visited once to Tirupati with NRIs for some app installation. First time I have met him. Then I was impressed with his infectious diseases activities and his, I think in the private sector with lot of academic this thing. I thought, sir, namaste, sir. Ivira, sir, is there.
Sir,
I'm
good evening,
seeing
sir.
Sir, good evening.
Sir, good evening, sir.
Sir, good evening, sir. Your voice is, sir, unmute, sir, please, sir. Unmute, sir.
Can you see my slides?
Yes, sir.
Sir, is it the full screen or like that, sir?
Yeah. One
I
second.
think
One second.
video
Yeah, good
people
evening,
should
Ivira, sir.
Sir, good evening, sir.
Yeah.
I think.
1 second, madam, please.
Sir, Ivira, sir, మాట్లాడండి సార్. సార్ అన్మ్యూట్ చేసుకోండి సార్. Kalyan, do you have any problem? Dr. Kalyan garu?
I'm coming back. I'm coming back. Yes. Screen?
Now I can, now you are able to hear me.
Yes, sir, yes, sir. Namaste, sir.
Yes, sir.
Namaste, namaste. Sorry, I'm late. I actually forgot about the meeting. I'm very sorry about it.
Sir, sir, sir.
Yeah, good evening, Ivira, sir.
Good evening, boss. Good evening. Hello,
Good evening, sir.
Yeah, fine, sir. Thank you.
Very good. Very good. Very good.
Namaste, sir.
Namaste.
Yeah. Good evening, everyone. Can you see my screen, madam?
Yes, yes, yes.
Yeah, sorry. There was some interruption with the network, so I had to quickly change back to the iPad mode. And that's the reason why there was, even the slide sharing looks little odd. Please excuse with me. Good evening, seniors and all my professors, teachers, and my colleagues. On a Saturday evening, especially at 9 p.m., I think I'll try to push it quickly such that we can have a good Saturday evening later on. The topic, which is definitely a little dry, but very important, that's none other than sepsis. So I would like to speak on only two aspects of sepsis, that's biomarkers and enhanced pathogen diagnostics. So we all know that we come across, I would like to start my presentation with a simple case. Can you see the case now? I mean, I'm actually scrolling through the iPad, so probably I'm not sure whether everything is perfect or not. Is this okay?
Madan can help.
Can you see the?
We are
Yes,
seeing.
sir.
We
Yes,
are
sir.
seeing. You
So
can
now-
go ahead.
Yeah, slide is visible, no problem.
Yes, sir. So is this patient in sepsis? So let me put it in short. A 65-year-old male patient has been referred from the rural hospital with fever, cough, and breathlessness of 5 days duration. He is a known diabetic. Patient is conscious but incoherent. So blood pressure is 130/70, pulse rate 120 per minute, 35 per minute is the respiratory rate, and 95% on room air, with sugars of 454 milligrams per deciliter. So this looks like an elderly male patient with history of fever. It could be sepsis, it could be diabetic ketoacidosis. So it could be anything. So how can we diagnose sepsis quickly? So that's the primary discussion of today's presentation. So, and also, why do we need to diagnose sepsis very early and very quickly? We know this to a certain extent, but we would like to re-emphasize with the available knowledge and also the possible information that's there with us right now. So let's go back to the definition of sepsis. Sepsis is a dysregulated inflammatory response to an infection that may lead to life-threatening organ dysfunction. So we know that to call it sepsis, we need to have an infection and we need to have life-threatening organ dysfunction, or at least some kind of organ dysfunction that can be dangerous, and there should be a dysregulated immune response. So there should be 3 factors at the same time. So now the point is, when a patient is presenting to our emergency room or casualty or to the hospital, it's very important for us to quickly analyze whether the patient is in sepsis or not, because we know the time is very important in sepsis, and like your myocardial infarction or your CVA, even in sepsis, the time is very, very important. Actually, it's more important than in myocardial infarction and CVA. So early recognition, sorry, here the slide has been cut. I'll read the whole slide. Early recognition through the use of screening tools is associated with earlier treatment and decreased mortality. This has been proven through various screening tools that have been used and are already available, which I would like to share them in short to you. We know the SIR score, which has been there from the beginning, and the quick SOFA score, which is the novel scoring system which we are right now using, to which if we add lactate, we call it as LQ SOFA score, quick SOFA score. And then you have Muse, Robson, and various other scores. So among these scores, if you see, the evidence level is high with SIRS, the quick SOFA, and the Muse score. And also evidence quality is high for all these 3 scores. So what are so among the available 3 scores, which score is the simplest of all is the quick SOFA score, because of its very simplicity. That quick SOFA has got only 3 important parameters. You can remember them as HAT as well, which I have not mentioned here. HAT. H stands for hypotension, A stands for altered sensorium, T stands for tachypnea. So if someone has a respiratory rate of greater than 22, they get 1 point. And if someone has altered mental status with GCS of less than 30, you get another point. You have to give another point. And if someone has a blood pressure, systolic blood pressure of less than 100, that's 1 point. So if someone has 2 out of 3 points, then we can suspect sepsis. We can suspect, I'm not saying the patient is in sepsis, we can suspect sepsis, and that's why this QSOFA is called as a screening tool. Now, the biggest advantage, if we have a side-by lactate measurement is possible. If we have a facility to measure lactate with an ABG machine, that's if you add lactate to it, and if the lactate is high, then given the ready availability of the quick SOFA score, adding lactate improves sensitivity very significantly. And now this is the best score that is being recommended across all health sectors across the world. So to simplify the whole thing, what we have been discussing from the beginning, we just have a patient where we wanted to know whether he has a sepsis or not. So the first thing, the simplest thing what we can even train our emergency room physicians is, even the doctors, MBBS, or even the physician assistants, is just ask them to learn HAT, H-A-T, adapt HAT. If someone has a score of 2 or more than 2, suspect sepsis, and get an immediate lactate done using the ABG, which is now readily available in majority of the institutes. We are almost there, nearer to sepsis. Now, once we reach to this point, we said this is a screening tool and we are almost there, but we are not there. And so what does actually the diagnosis of sepsis requires? Sepsis requires some more information in the form of organ dysfunction and also in the form of microbiological documentation. And you have, if you have a facility, the supporting evidence of the biomarkers. The point is, after we have done a score and we identified that the patient is likely to have sepsis, the biggest thing, the first and foremost thing which we want to do is to give him an antibiotic in order to save him from the infection. So that's what we call it as a golden hour in sepsis. So now the golden hour in sepsis, this is what I was trying to tell you in the beginning, I was trying to emphasize on the beginning. So you see the survival fraction, as the time goes, it goes down, and the effect of antimicrobial initiation as it starts early, it improves. So the time is life in septic shock and in sepsis. And considering this fact, now the question for us when a patient reaches to us with sepsis is to confirm the diagnosis of sepsis. Now we have screened the patient, we know that it is sepsis, probable sepsis or possible sepsis. Now we want to confirm the diagnosis of sepsis. So to confirm the diagnosis of sepsis, going back to the previous slide, you can see the biomarkers can be of some help, and or we have to immediately get a microbiological documentation to say that it is sepsis. So what are the various biomarkers that are available for us right now, which we can use immediately? Primarily, there are only two that can be used very easily. One is C-reactive protein, the other one is procalcitonin. We know C-reactive protein has got low specificity due to increase in CRP from non-infectious causes. Procalcitonin appears to be relatively better. It has got better sensitivity of around 60 to 70%. It rapidly increases in 2 to 4 hours after bacterial endotoxin reaches a peak of 6 to 8 hours and remains high for 24 hours. But still, there are non-infectious causes. Even procalcitonin can be high. Even simple chronic kidney disease or in usage of certain antibiotics like piperacillin, tazobactam, all these can also increase procalcitonin. But still, with the available resources, let's see with the available biomarkers which we have, what could be how procalcitonin can be used. So I would like to emphasize on procalcitonin because of the practicality of using it right now in the present day conditions. Also to add a small note on CD11, CD64, which are very good in sensitivity and specificity, but not readily available. Pancreatic stone protein and TNF-alpha are also good, but none of them are readily available. But procalcitonin is available as a point of care. Majority of the hospitals have this in the form of a point of care test. And let's see how procalcitonin fares better in considering as an immediate biomarker for sepsis. This is the first trial that came up on procalcitonin, PRORATA trial. This trial happened in 2010 and was published in Lancet. And it has got some good guidelines stating how to start antibiotics. When procalcitonin levels are less than 0.25 micrograms per liter, antibiotics should be strongly discouraged. We have to think of conditions other than sepsis or other than bacterial infection otherwise, because even dengue can cause sepsis, even viral infections can cause sepsis. So we have to think of other possibilities of sepsis other than the bacteria. So if there is points between 0.25 and 0.5, antibiotics still needs to be discouraged, but can be considered based on the patient's condition, but definitely encouraged if it's more than 0.5. And more importantly, the trial suggested another important aspect. More than the initiation of antibiotics, the procalcitonin is very helpful in stopping the antibiotics. If the patient has a value of 0.25 micrograms per liter, less than 0.25, then we must stop antibiotics. And the other thing is, if we have a procalcitonin value which is high, but there is decrease by 80% or it drops to less than 0.5, we can even encourage stopping the antibiotics. This is very, very important, which has been further studied over the last 10 years, not just 1 year, 10 years, and it has been published through PROGRESS trial. PROGRESS trial is another important trial that was primarily on procalcitonin, and in this they checked for all possible infections: community-acquired pneumonia, hospital-acquired pneumonia, pyelonephritis, bacteremia, and then they followed up for a given period of time up to 6 months with standard of care and procalcitonin-based treatment. Like standard of care in the sense, previously we used to have standard of care stating that in our textbooks of antibiotic textbooks stating, yes, we have to give medicated antibiotics for 7 to 10 days for this condition, for 15 days for given condition. Similarly, we used to have so many recommendations. Now, all this is now being slowly understood in a different way. Should we really give it? And Progress trial showed it in a different way that it's not required. So Progress trial had some primary endpoints to identify whether the patient had new infection with Clostridium difficile or multi-drug organisms. And also they had secondary endpoints, which actually suggest to look at length of therapy with antimicrobials, mortality at 25 days, and multi-drug resistant organisms and mortality at 6 months. And so what they identified was the primary endpoint showed procalcitonin group had lesser mortality and when compared to standard arm with standard care of treatment. And also, more interestingly, they also identified some more secondary endpoints, which also showed, I'm not sure whether you can see them, the recurrence of infections like community-acquired pneumonia, healthcare associated pneumonia, acute pyelonephritis, and any bacteremia. In majority of the cases, the length of therapy was very less compared to this standard of care using the methodology which we have identified in the beginning, like based on the value of procalcitonin. So, would like to say that we can use procalcitonin in a situation where probably a patient has come to us, we have done a quick SOFA scoring, added lactate to it, suspected sepsis, get a procalcitonin done, and because the procalcitonin, if you have a point of care facility, the procalcitonin can be obtained in less than 1 hour, which means that we have a ready situation where probably we are sure that the patient requires antibiotics or not, and what kind of, then the point comes, what antibiotic has to be given. So now what the timing of antibiotic, which we call it as golden hour of sepsis, is something, timing of antibiotic is very important when you have sepsis is definite or probable. So a quick SOFA score saying that there is a possibility of sepsis, and the procalcitonin stating that yes, it is sepsis. Now we have to administer antibiotics immediately, ideally within 1 hour of recognition. So now we have enough time. The patient has come. SOFA scoring takes hardly 2 to 3 minutes. Lactate takes, you take a sample, send it for lactate, send it for procalcitonin, less than an hour. You are having a picture whether the patient is having sepsis or not. So if sepsis is possible, administer antimicrobials immediately, ideally within 1 hour, and rapid assessment of infectious versus non-infectious cause of acute illness has to be done simultaneously. And if you are not sure that it's not probably infection or it could be viral, we can wait upon, and slowly after the availability of the reports, we can wait even up to 3 hours if the sepsis is not definite. Now, this is the most important thing that came up, that has been there since 2016, Surviving Sepsis Campaign recommendations. For adults with sepsis or septic shock and high risk of multi-drug organisms, which means that significant comorbidities and has been hospitalized quite a few times in the past, we suggest using 2 antimicrobials with gram-negative coverage for empiric treatment. This is in a situation like India, where we have a huge number of diabetic population associated with further other comorbidities like chronic kidney disease, heart failures, who all present to us with recurrent infections. For adults with sepsis or septic shock with low risk of MDR organisms, we suggest against using 2 gram-negative agents for empiric treatment. This is probably young adults who do not have much comorbidities. And for adults with sepsis or septic shock, we suggest against using double gram-negative coverage once the causative pathogen and the susceptibility is sorted. Now the question comes, how do we do this quickly? Now, Surviving Sepsis Campaign says that we have to use 2 antimicrobials, and at the same time, at the end, they're saying that you need to change them to quickly the expected antimicrobial or find the causative pathogen and the susceptibility immediately and change to the antibiotic that is definitely useful to the patient. So, now having said that, you have SOFA score to identify quickly or to screen quickly with lactate. We have a procalcitonin to certain extent to help us, yes, the patient fits into sepsis. with point of care facility available. Now, can we really do much faster with respect to identifying the organism also? So there have been huge technology and progress in the last decade with the usage of rapid diagnostic tests. I'm sorry, the screen appears to be very small here, but I think some you can see. Among these rapid diagnostic tests, the hybridization tests, that's FISH and PNA FISH, are one of the types which were there early, but now they are now typically replaced with polymerase chain reaction PCR tests, especially multiplex PCR, which is commonly used in majority of the institutions. And the other one is MALDI-TOF, which is also mass spectrophotometry, which can also be helpful. And in future, we get proteomics and photonics, which also are also in the pipeline as rapid diagnostic tests. What do these rapid diagnostic techniques help? Before that, what are the present available rapid diagnostic tests? The best thing which I would like to add upon, if you can see, FilmArray is the one which actually what we are using right now in a majority of the centers across India, across the world, which is provided by the company called Biomiri in the form of BioFire. It's an RT-PCR technique, and it can detect 24 microorganisms with a specificity of 88 to 100%, and sensitivity with a specificity of greater than 98%, and we get the results in 1 hour. And this is the really wonderful point which we have started using in our center. This is the reason why I wanted to present this. When Krishna Prashanti madam asked us, do you have anything specifically which you can present that is useful in terms of sepsis? Yes, the rapid diagnostic techniques are now being readily available even to identify the organism in less than 1 hour. So now let us see from the Surviving Sepsis Campaign recommendation of identifying the organism as early as possible in the golden hour. Yes, it is possible now to get things in the golden hour. And this is how the things have changed over the period of a decade. This is what I've told you, the BioFire, which we use right now in our hospital, which I'll show you shortly, has gotten blood culture identification panel, which reduces the time to organism detection by 70%. Now you just take a sample of blood, draw it, put it in a blood culture board machine. You get the signal in less than 4 to 5 hours, and immediately you subject that sample to BCID panel. It identifies the organism and also identifies the resistance patterns, and you are there. You identify the patient, and then the patient is going to be treated with the appropriate and the accurate antibiotic. Now we have done another interesting aspect here. Now to get this means that you have to wait for another 5 hours, which means that definitely another 5 hours are required because your signal has to come from the blood culture field. So there was one paper that was presented in Japan, where they started seeing procalcitonin levels. Based on the high procalcitonin levels, they were subjecting that sample directly to the BCID panel. And we are also doing that in a form of a small pilot study in our hospital. In those cases where there is very high procalcitonin, we are immediately subjecting them to the BCID panel. In 2 cases, we got a wonderful result, and then it helped to survive the patients who were in shock. And I'll show you how is the report. Now this BCID2, this is blood culture identification 2 panel, also helps in identification not only the organism but also the resistance patterns of carbapenimases, various carbapenimases like class A, class B, class D, that's KPC, NDM, IMBIM, OXA48, and also MCR gene of colistin, and also ESBL genes, CTXM gene, and methicillin resistance genes can also be identified, and VAN A, VAN B can also be identified, which is missing actually in this slide. Now, I'm just stopping here. People have asked us how much this costs us. Like a patient coming to the hospital, quick SOFA doesn't cost much. Procalcitonin, now we can get it for around 1,500 rupees to 2,000 rupees. Up till there, it looks quick. But this appears to be a little costly affair because the candidate itself costs us around 10 to 12,000 rupees. So at a bare minimum, we have to charge around 15,000 rupees. So people were thinking, can we have any other options where probably we can start detecting, it may not be the organism, but the primary point is to detect the resistance here, because we are giving carbapenem, or we might be giving piperacillin tazobactam, or we might be giving cephalosporin considering the patient is in sepsis. But based on our available antimicrobial stewardship program in our hospital, we might suggest probably in a patient coming to the ICU, probably give this antibiotic. But we are not sure whether the patient is already having carbapenem resistant or not, and whether the drugs which we are giving are useful or not, because straight away we cannot give a patient colistin without knowing what bug is lodging and whether it is actually multi-drug resistant or not. So what happened was, in 2018 or 18, I remember, I went to Greece, Volos, to just learn a small understanding of a lateral flow assay, which I am now showing it to you, which is called as an immunochromatographic assay, which comes with a small strip method, which costs just 10 euros. This assay helps us in identifying the same genes of NDM, IM, and also OXO48 at hardly 500 rupees, which is going to be a wonder point. Once, similarly, if you have a blood culture done, if you have a signal, or if you have some group from urine culture or in ET secretion, you can directly subject it to lateral flow and identify. Of course, it's a little slower when compared to the BCID2, which is the multiplex PCR model, but it is definitely going to be very effective, cost effective with just 500 rupees. I think we can, this assay is still not available right now in the market. Along with a few centers in India, we are actually doing a small study on this, and we found it to be quite useful. So even this has got a fantastic sensitivity and specificity down there, which you can see with Carba or the CTXM, and it helps in accurately identifying the resistance genes the patient is lodging. So after having said all this, the most important thing which we should also improvise upon is developing our own antimicrobial stewardship program. So there was a molecular diagnostics were used by many hospitals, but they identified that in order to improve the mortality risk, we need to add rapid diagnostic tests with antimicrobial stewardship program. And without its presence, it's not going to be easy. But it's very easy to use this terminology. People use it very comfortably, easily, and ASP, antibiotic stewardship, antimicrobial stewardship, but it needs lots of involvement. And we definitely are spending a huge amounts in running institutes, critical care units, especially big cath labs and cancer centers. But it is very important these days, especially in a country like India, to establish antimicrobial stewardship programs, have our own clinical microbiologists other than the regular microbiologists in the laboratory, and improvise upon the existing status to improve the diagnosis, infection prevention, and also the management. Now, I came across an interesting discussion a few days ago when somebody was saying that there's going to be huge medical tourism to India, but the only negative factor that's going to hit us is the lack of antibiotic stewardship and the resistance bugs, huge amount of resistance bugs in our areas. So if we have RDTs, it's must that we also develop the antibiotic stewardship program. So the three core aspects of improving sepsis management, which is the title of discussion today, is to have those biomarkers readily available, start using rapid diagnostics tests. If it is possible, if the patient is affordable, we can use those tests which are the BCID2 panel, that is FILMARRAY by the Biomiri PCR test, or slowly these lateral flow assays might be available, and that can be of great help to us in identifying the patients with multi-drug resistance. The future also has some more interesting things like nanoplasmonics, silicon plasmon, and nanophotonics. These are going to identify the bugs in a similar way, not only the bug, but also the resistance patterns at point of care devices just next to your bed in the ICU. We're going to get the bug immediately, directly from the blood sample, and hope that day is not far from near. And this is our present ICU at Sri Hospital. We have a negative pressure critical care unit. This picture was taken during the COVID time. And This is our laboratory with the automated culture systems and the PCR systems. And these are the reports that we have obtained from various patients. For example, this patient has got Klebsiella pneumonia identified through blood culture. With you can see the genes. If you can see, there's a gene, NDM gene, and OXA48 gene, and CTXM gene. So if we are able to get this report quickly, then probably we are going to save the patient, identifying that the patient has a combination of NDM and OXA48. We are sure that we need something bigger, not just colistin, maybe because there is OXA48 also, probably something as synergy testing with aztreonam and ceftazidimab, avibactam has to be done, and a combination of those have to be given. So if this is probably not available, we may have to wait for a long time until we get this basic Vitek-2 report, which has come after 72 hours stating the same thing, that the patient had Klebsiella pneumonia, huge resistance across the antibiotics. So these investigations or these modalities look very tough on us, or look like these are not possible, that these are not possible at almost all the centers. Very few centers can do it. But when we can do it when we were able to do it in Guntur, we thought it is possible at every place to do it, even in smaller centers. The reason being, on an average, a patient starts spending, say, for example, 10,000 rupees in a critical care unit for the basic services, and for the antibiotics, say another 10,000 rupees, which is coming up to 20,000 rupees, and say for all the rest of the things. And the average spending value for a critical care patient in an ICU is 20 to 25,000 rupees, and sometimes even more than that, based on whether than a ventilatory support or any other things. Considering that amount, this is going to be relatively very cheap, even if we start using multiplex PCR more often than not. And when we started multiplex PCR in our hospital, when we kept this in our hospital, we thought we will be doing it maybe 1 test per week or 2 tests per week, where we're almost doing 1 to 2 per day right now. So it is actually helping us in picking up the patient in the right time, and also giving them. I have not put many patients' histories here because that's given the time limitation. But we have seen huge number of patients coming in septic shock. We were in a confusion what to do with this patient. There were cases where there was appendicular perforation was there. Now we were not sure whether that was Enterococcus or E. coli, and BioFire helped us to pick it up very fast because we had a high procalcitonin. We immediately subjected to BCID2 panel. We diagnosed and immediately put him on colistin. The patient recovered in less than 4 hours. We took him up for surgery. That is the amount of advantage which we have in bringing up these new modalities, and we hope to see them more and more in near future. This is another patient where you can see there is some disadvantages openly because of the short time. I'm not putting everything, but there are certain disadvantages. See, for example, here you have 2 organisms at the same time. One is Escherichia coli and Klebsiella. In a situation like this, we need not be worried because the gene that is important for resistance is the most important one. So based on the resistance gene, we can decide upon the antibiotic immediately. Then probably we waited upon the final result with the Vitek, and it was identified to be Klebsiella pneumonia by the conventional method. So the primary point which I would like to stress upon is selecting the antibiotic is going to be very, very important without losing time in order to save the patients. So this has been clearly proven across the sectors. The biggest problem in India is the literature from the West is completely different from the situation in India, where multi-drug resistance for them in carbapenem, they still use cephalosporins or extended spectrum beta-lactam still. In case of a patient getting admitted to an ICU. But in India, we have clearly seen that if we come across any ICU in this country, if we speak to the critical care specialists or an infectious disease specialist across the country, they would say the carbapenem resistance is more than 50%. Considering the fact that the carbapenem resistance is more than 50%, and with the presence of so many genes, without understanding what bug is the patient lodging, with so many comorbidities, and with a huge amount of immune problems like cancer patients or heart failure patients, it's going to be very difficult, and that golden hour is going to be very, very important because as we lose time giving them carbapenem or third generation or fourth generation or ESBLs, the patient is likely to worsen rather than improve. So this is we have started using this even in our hospital. Now this is called as Coris Bioconcept. This is the European kits which we are using, which is helping us to identify. I think it's faint here. It's detecting NDM gene here. And you can see here the resistance. There is clearly the resistance patterns. After 48 hours, we got the final report stating the same thing, that the patient has E. coli with an NDM presentation sensitive only to colistin and resistance to suppressant sulbactam and meropenem. And this was another patient where he had NDM and OXA48. So I think I've taken huge time. I mean, at least try to quickly squeeze in. Thank you for the opportunity. Anything, I think this is more of a discussion, because what I might have spoken probably needs more discussion. Thank you.
Thank you very much, sir, for your excellent presentation. Now I request Dr. Aguirre, sir. Yes, sir. Yes, sir. Please, sir.
Wonderful lecture. Sepsis. The problem is we can get lactate easily, so that for every ABG we're getting lactate. Lactate, whether sepsis are not present, we can see. Procalcitonin will take some time. That is my doubt.
They are saying availability is within 1 hour.
Yes, sir. Now we have point of care facilities for procalcitonin. We have point of care.
So within 1 hour, they are getting, it seems.
Yes, sir. We can get it.
Sir.
1 hour is okay.
We need to have the device, point of care device, BRAMS PCT, BRAHMS, BRAMS procalcitonin. If we have that device, it's a point of care device. It's not very costly. It's around 7 to 8 lakhs. And if you have that device, we can get the report in less than an hour. It's a small cartridge-based, kit-based.
Thank you, sir.
Yes, sir.
Madam, I would like to add 1 or 2 issues.
Sir, please,
Sir, go ahead, sir.
I would like to share a screen. Can you stop sharing?
Yeah. Yes, yes.
The presentation was outstanding. The content is current and is the need of the hour. The issue with sepsis-related biomarkers is most of the work is done in ICUs in the United States on one side of the Atlantic and in the European Union. And there are not much hard data from India. With regard to procalcitonin, I want to share our publication which came in the Indian Journal of Medical Research.
Yeah.
We used the serum procalcitonin. What is its utility to answer 2 questions? The ROC analysis had shown that at a cutoff of more than 3.2 nanograms per ml, the sensitivity and specificity of serum PCT in predicting bacteremia was pretty good, 81.1, 63.3. At a cutoff of more than 3.74, at the initial presentation, it had predicted in-hospital mortality. The sensitivity and specificity were 65% plus. The ROC looks like this. We had in this study the following groups: patients with bacteremia, patients with malaria without any bacteremia, patients with an evident focus of infection, patients with proven leptospirosis, proven dengue and scrub typhus. And the ROCs are pretty rugged. The point what I'm trying to make is these are hard Indian data which are to be extrapolated to the Indian scenario. The other one is, this is one thing I wanted to mention. The other thing is in our institute, we have a ICC, Infection Control Committee, and this is available in our website, you can check out this under the tab quality. There is a tab quality at our website. So in the new initiatives quality, if you check out, these data are available, and it addresses the various outcomes and KPIs for WAP, CLABSI, COTI, SSI, the SIR, the hand hygiene complaints, and the needle stick injury incidents. We bring out an antimicrobial stewardship hand pocket guide, which is updated every quarterly based on our own data.
Fantastic, sir.
This is in public domain. This is in public domain, so it is accessible to everyone. A wonderful presentation, Dr. Kalyan. Thoroughly enjoyed it.
Thank you, sir.
Sir, I will.
Sir, Abhirav garu.
No, nothing more, nothing more.
Sir.
Sir, MBR Sharma sir. Unnara sir?
Prabhakar sir, Manoj sir.
Yeah, so.
మీరు వాయిస్ బాగుండదు అనుకుంటా.
Madam. Prabhakar sir unnara sir?
Yeah, very much there, of course.
Sir. Sorry, sir.
Sir, before closing, please that reinforce the Eluru's.
Sir. Sir, Eluru APA Journal CME 12th March, sir, in Ashram Medical College. So we request all of you to kindly make yourself comfortable in attending the Journal CME. We request all of you to motivate all other medical colleges in and around Ashram Medical College for maximum participation. And we'll have the EC meeting on that day, and we have to discuss about the state conference dates and other things. And we have to tell about what the National API is doing about to all the EC members. We request all EC members, particularly all the zone vice chairpersons, better to attend on that day. And any other matter with the permission of Dr. Ivy Rao, sir. Otherwise, we can conclude.
Nothing more, madam.
Sir, thank you very much, sir. So I have to thank particularly Dr. Uday sir and Dr. Kalyan, and you have to excuse me also because I was very persistent in getting the titles, everything. I was very, I think you are getting bored for my continuous messages also. But I have to thank Kalyan.
Actually, Uday was asking me, Kalyan, why don't you speak on integrated medicine? I said, no, madam wanted sepsis this time.
No, I thought you can give lecture in the state conference or something, because we want to give morely focused on the practicing doctors and postgraduates. And sepsis is a very important topic. I think really you did justice to that topic. And sarcopenia is also a very important topic, which most of us will, we are not taking care in our regular day-to-day practice. And because we are physicians, we have liberty to speak on anything when compared to our subspecialist colleagues. So next time it is up to you in the EC, you can decide who. I think I want all the young doctors, assistant professors, associate professors in the respective medical colleges who want to volunteer. I want from mainly the general medicine, not other subspecialists, because they are not allowing us in their respective this thing. So I request particularly all of you to encourage your juniors, at least from Srikakulam. I think sir can guide us, Srikakulam or Vijayanagaram. We have to give opportunity to them, and I'll ask from Kuppam, Chittur, so that new doctors, new faces should come and join for the giving lectures. Thank you very much, sir. We'll be meeting you again in Eluru on March 12th. Good night. Thanks to VDO Technologies for your continuous support.
Thank you, sir.
Thank you, madam.
See you the meeting, sir. Namaste, sir. Namaste. Thank you very much, sir. Thank you.
Namaste.